Hello and welcome, fellow student doctors. Today we will discuss anti-cancer monoclonal antibodies. In our pre-med days, we dreamed of the day when we would learn how to treat cancers. Today is that day, friends. I am super excited to present this lecture to you all. In total, we will cover 13 drugs, but I condensed them into 6 slides and will give you the background and strategy necessary for you to score big on test day. Let's get started. To prepare you for test day, you will be able to 1. Explain the mechanism of action and side effects for the following anti-cancer monoclonal antibodies. I know it looks like a lot, friends, but we will learn together how to make this material manageable and high yield for test day. Let's start with alemtuzumab. To understand alemtuzumab, you must understand the number 52. CD52 is a cell surface protein found exclusively on mature B cells and mature T cells. For drug selectivity, this is ideal because alemtuzumab can directly seek out and bind exclusively mature B cells and T cells. That's why I titled this slide Alem, a 52-year-old mature man. Let me explain. Every time I read about alemtuzumab, I think of a 52-year-old mature man named Alem to recall this drug's target, CD52, and where it is found on mature B and T cells. And so, once bound, alemtuzumab recruits natural killer cells and complement. The natural killer cells bind the Fc region of the bound antibody and release their granules all over the mature B and mature T cells, inducing apoptosis. This is called antibody-dependent cellular cytotoxicity, ADCC, a mechanism common to many of the drugs we will discuss today. Moreover, complement is also recruited by the bound antibody and ultimately leads to cell lysis and subsequent destruction of the mature B and T cells. In terms of clinical uses, alemtuzumab is used to treat chronic lymphocytic leukemia, CLL. This makes perfect sense, doesn't it? See, the cancer is called chronic because the cells mature to chronic or older cell forms in CLL, that is, mainly mature B cells. So it makes logical sense to use an antibody that seeks out and destroys mature B cells that are overproduced in CLL. Also, my mnemonic Alem as a 52-year-old man helped me recall that this drug is used in CLL, a cancer that commonly occurs in 52-year-old men. The mnemonic takes us far, friends. Similar logic can be used with multiple sclerosis, which is a mature B and T cell disorder, hence the use of alemtuzumab. In terms of side effects, there is an increased risk of infection and autoimmunity. Of course, right? We are knocking out mature B and T cells, so logically, these risks make sense. Okay, now, let's move on and talk about rituximab. Rituximab is one of those drugs you must know cold for test day. Literally, know this drug better than you know your first and last name. Okay, it is that high yield, so listen up. The key to understanding rituximab is to know that it is selective and exclusive to B cells only. What do I mean by this? This antibody seeks out and binds CD20, a cell surface protein exclusively found on B cells. To be clear, CD20 is found on all B cells, both immature and mature forms. Once bound, the same processes we discussed with alemtuzumab occur. That is, antibody-dependent cellular cytotoxicity via natural killer cells along with complement recruitment. Ultimately, these processes lead to apoptosis and cellular destruction respectively. The clinical uses of rituximab are very straightforward if you understand that CD20 is specific and exclusive to B cells only. Essentially, rituximab can be used in basically any disorder that has a B cell component. For example, if the B cells are malignant, like in chronic lymphocytic leukemia or lymphomas, use rituximab. Moreover, if B cells are creating and releasing autoantibodies in autoimmune conditions such as rheumatoid arthritis and autoimmune hemolytic anemias, use rituximab to decrease the number of B cells and subsequently the number of autoantibodies those B cells can produce. In terms of side effects, there is one main side effect to know: the risk of progressive multifocal leukoencephalopathy, PML. Why is this a risk? Well, in the central nervous system, B cells help control the JC virus to prevent reactivation. However, as we have learned, rituximab, through binding CD20, eliminates B cells, raising the risk for JC virus reactivation and clinical progression to PML. Before moving on, I want you to actually pause this video. Go look yourself in the mirror and then say, rituximab binds CD20 found exclusively on all forms of B cells. I guarantee you, friends, this will get you a point on a class exam, a Q bank, and hopefully on test day. Moving along, You may have looked at the drugs listed as cytotoxic T lymphocyte-associated protein 4, CTLA4, and programmed death ligand and receptor antibodies and thought to yourself, how am I ever going to remember these? Well, friends, remembering these drug names is far less important than understanding their role in T-cell disinhibition. Take a deep breath and let me explain. So, pictured here is a cancer cell in purple, trying to deactivate a cytotoxic T cell in blue. That cytotoxic T cell is attempting to kill that cancer cell. So, to deactivate this angry cytotoxic T cell, the cancer cell expresses PD ligand 1 and/or B7, also known as CD8086, on its cell surface. Let's walk through both of these. When PD ligand 1 on the cancer cell binds PD receptor 1 on the cytotoxic T cell, and/or B7 on the cancer cell binds the CTLA4 receptor on the cytotoxic T cell, this leads to T cell exhaustion, a fancy way to say T cell deactivation. Now, listen closely, friends. If the cytotoxic T cell is deactivated by the cancer cell expressing these ligands, it cannot kill that cancer cell. So, that cancer cell survives this encounter and proliferates, creating more cancer cells resistant to cytotoxic T cell destruction. Cancer cells are pretty clever, huh? Good thing scientists and drug designers are even more clever. Let me show you. See, we can give the patient antibodies that bind PD receptor 1, PD ligand 1, or CTLA4. If these receptors and ligand are bound by antibodies, they cannot interact with their respective receptors and ligands to cause T cell deactivation. So, treatment is said to lead to T cell disinhibition, a fancy way to say that cytotoxic T cells' killing ability is restored. Watch out, cancer cells! This disinhibited T cell is coming for you. Overall, for testing, the key words to know are T cell disinhibition. That's the phrase test makers love to use when testing these agents. Literally, you might as well use it as a knee-jerk reaction. I started to, and it really paid off, but you really must understand this whole signaling process because they might take the question in a different direction. Moreover, each of these antibodies have names. Being transparent, friends, I humbly scored very well on step 1, and I totally did not know these names walking in the test day. But I knew the signaling very, very well. Test makers usually give you the names of these drugs or scenarios and then ask mechanistic questions based on these specific antibody targets. So really just know the signaling in this slide. Lastly, let's briefly discuss clinical uses and side effects. Essentially, just know that these agents treat various cancers and increase the risk of autoimmunity, which makes sense because they are leading to T cell disinhibition. That is, a more active immune system. Now, we have come to another landmark drug, bevacizumab. Again, know this one better than you know your first and last name. Yes, it is that high yield. You may have noticed that the B and V in bevacizumab are both highlighted in red. Let the B remind you of blood and the V of vessels. That's right, friends. Bevacizumab inhibits blood vessel growth to treat cancers. This is logical, right? If a cancer lacks blood supply or cannot expand its blood supply, it will die or be limited in its ability to grow. Before we discuss bevacizumab, you must understand its target, VEGF or vascular endothelial growth factor. VEGF, as its name suggests, enhances endothelial cell growth. That is, it enables the growth of blood vessels. Particularly, it does this in two ways. First, VEGF can promote angiogenesis, which is the growth of blood vessels from pre-existing blood vessels. So, pictured here is a pre-existing blood vessel. And through angiogenesis, induced by VEGF, that vessel can grow. Secondly, VEGF can induce vasculogenesis, which is the formation of blood vessels de novo, or the formation of new blood vessels from scratch. And so, bevacizumab decreases both angiogenesis and vasculogenesis by binding VEGF. In terms of clinical uses, it's straightforward. Use bevacizumab to decrease blood supply in various cancers and certain high-yield eye disorders, such as angioproliferative retinopathies and wet age-related macular degeneration. This makes perfect sense though, right? The side effects are also straightforward. This drug interferes with blood vessel formation, so logically this can lead to hemorrhage and/or blood clots. Also, wounds are vascular areas since tissues are undergoing repair. So, in patients receiving bevacizumab, they may have impaired wound healing. This point often goes under the radar with students, and I can tell you from experience, this is a very high yield point that you want to put in the back of your mind for test day. And so, again, bevacizumab is one of those drugs you just really gotta know well for test day. Again, friends, pause this video, go look yourself in the mirror and say, bevacizumab binds VEGF. It might just get you an extra point on test day. Moving on, let's talk about trastuzumab, a drug known for its use in treating HER2-positive breast cancer. Let's use this diagram to detail its mechanism of action. So, HER2 is a cell surface receptor that can be overexpressed in breast and gastric cancers. Focus mainly on its association with HER2-positive breast cancer. Moreover, trastuzumab is an antibody designed to bind the HER2 receptor. Once bound, the antibody receptor complex is internalized via receptor-mediated endocytosis, and eventually, both antibody and HER2 receptor undergo lysosomal degradation. Ultimately, this leads to decreased proliferation of cancer cells because they no longer have as many HER2 receptors on their surfaces, sending growth signals. Pretty cool, huh? I should mention that the antibody, once bound to the cell surface receptor, can activate complement destruction and antibody-dependent cellular cytotoxicity via natural killer cells, as we have previously discussed for other agents, but the mechanism most commonly tested is presented here. Okay, now really pay attention to the major side effect of trastuzumab: cardiotoxicity. Specifically, this drug is infamous for causing dilated cardiomyopathy, which is thought to arise through free radical formation in the heart tissue of patients receiving this drug. Before leaving this slide, to remember all the key information about trastuzumab, use this mnemonic. Treatment is a travesty to the heart and HER2. Travesty for trastuzumab, heart because of its side effect, and HER2 for its target. Thus, treatment is a travesty to the heart and HER2. It flows, doesn't it? Now, only 2 drugs left. Let's tackle them on the next slide together, shall we? Now, let's discuss cetuximab and panitumumab, which are antibodies that seek out and bind the epidermal growth factor receptor, EGFR. Test makers use these drugs to test your knowledge of EGFR signaling. Let me explain. So normally, the cell surface EGFR is bound by a growth factor, which leads to the activation of the RAS protein, and ultimately, cellular proliferation. Cetuximab and panitumumab can block the growth factor from binding to the EGFR receptor. Please note that this leads to a similar process that we discussed with trastuzumab, that is, receptor-mediated endocytosis and lysosomal destruction of the receptor, along with activation of antibody-dependent cellular cytotoxicity and complement destruction. Whew! Ultimately, with decreased presence of this receptor on the cell surface, cancer cell proliferation decreases. Now, listen closely if you want to score big on test day. The clinical utility of these 2 drugs depends on the RAS protein being wild type, that is, not mutated. Because if the RAS protein is mutated, the cancer cell can proliferate without EGFR activation, because RAS no longer depends on EGFR signaling to become activated. So the mutant RAS protein is constitutively active and inducing cancer cell proliferation. Bottom line, if RAS is mutated, then cetuximab and panitumumab are not the drugs of choice anymore for an EGFR-positive cancer. Overall, this background makes the clinical uses and side effects relatively straightforward. Basically, use these drugs for cancers that overexpress EGFR, but make sure the cancer has wild-type RAS. Again, these drugs are most effective when RAS is wild-type, a commonly tested point. As for side effects, I like to think of them as epidermal cell side effects and drug processing side effects. Think about it like this. These drugs bind to the EGFR, so these receptors are on epidermal cells, like the skin, where a side effect is classically, and I mean classically, an acneiform rash, and digestive tract cells, which are also epidermal cells, hence diarrhea. Moreover, elevated LFTs may be observed due to drug processing in the liver. Okie dokie, That was a lot of information. Now, let's do a flash quiz to test your understanding of this material. The question reads that a patient has begun treatment for renal cell carcinoma with an antibody that binds vascular endothelial growth factor, VEGF. Which of the following might be observed while the patient is on treatment? A. An acneiform rash. B. Reactivation of the JC virus. C. Cardiotoxicity. Or D. Delayed wound healing. D. Delayed wound healing is the correct response. This makes sense. Bevacizumab's B and V, underlined here, stand for blood vessel. By binding VEGF, less blood vessels can be made, leading to decreased blood supply and nutrients to healing tissues. Hence, delayed wound healing. High yield, know that for test day. In terms of the other answers, an acneiform rash goes with cetuximab and panitumumab. Reactivation of the JC virus is a dangerous side effect of rituximab. And cardiotoxicity is classic for trastuzumab. I know this material can be overwhelming, friends, but I am confident that by reviewing this lecture and doing Q-Banks, you will be prepared for test day. Be easy on yourself. This is challenging stuff. Okay, let's now summarize on the next slide. Thank you for sticking with me throughout this lecture. We covered a lot of material, so let me provide a few key takeaways for each of the main set of drugs for you to know on test day. Starting with alemtuzumab, know that alemtuzumab targets CD52, which is a protein found exclusively on mature B cells and mature T cells. This enables alemtuzumab to be of clinical use in treating chronic lymphocytic leukemia and multiple sclerosis. To help you recall some of the facts associated with alemtuzumab, use the mnemonic alem is a 52-year-old mature man. Next, rituximab. Rituximab targets CD20, which is found only on B cells, both mature and immature forms of B cells. Friends, you cannot leave this lecture without knowing this fact about rituximab. It is so high yield, I guarantee it, you will see it somewhere on your path of Step 1 studying, and you must know it for test day. It will probably get you a point. Also, you should know that rituximab is essentially used in any disorder with a B cell component. Next, CTLA-4 and programmed death ligand receptor antibodies. Know that these agents foster T cell disinhibition to restore cytotoxic T cell destruction of cancer cells. Friends, I confidently walked into test day not knowing these antibodies' names because, honestly, the majority of practice questions I did focused on their mechanism of action or their targets and wanted me to understand signaling in the important phrase T cell disinhibition. Next, bevacizumab. Know that bevacizumab targets VEGF to decrease blood supply to cancers and certain eye disorders. Again, like rituximab, these are probably the most high-yield facts for test day. Make sure you know them both. Next, trastuzumab. Know that trastuzumab targets HER2 and is infamous for causing cardiotoxicity, specifically dilated cardiomyopathy. Remember facts about trastuzumab with the mnemonic, treatment is a travesty to the heart and HER2. Lastly, cetuximab and panitumumab. These agents target EGFR and can cause an acneiform rash and are most effective when RAS isn't mutated. Make sure you understand the discussion about RAS being mutated versus wild type. That will most likely help you get another point on Step 1. And so, friends, if you enjoyed this lecture, give it a big thumbs up and leave a comment, even if it's just to say hello. And always remember, there is a great, big, beautiful tomorrow.